Welcome to Deep Dive Dialogue. Our topic for discussion today is genetic mutations and molecular alterations in non small cell lung cancer, implications for diagnosis and treatment. Non small cell lung cancer is driven by diverse genetic mutations and molecular alterations. These biomarkers guide precision diagnostics and targeted therapies, improving patient outcomes. Comprehensive genomic profiling enables personalized treatment strategies, facilitating better response and minimizing toxicity, thus transforming lung cancer management in modern oncology. We are honored to have Dr. Chirantan Bose with us to discuss this topic. Dr. Chirantan Bose is head of Department of Molecular and Precision Oncology at Mumbai Oncocare Center. He is a distinguished leader in applied molecular oncology with over 2 decades of expertise in cancer diagnostics and precision medicine. Dr. Bose has been instrumental in bridging the gap between cancer genomics and personalized medical oncology, driving innovative research in liquid biopsy, particularly in circulating tumor cells, for early cancer detection and monitoring progression. His global career spans impactful roles across renowned oncology institutions in Asia, US, Canada, Australia, Africa, and GCC. A leader in establishing state of the art pathology and oncology services, Dr. Bose excels in creating patient centric, data driven, and cost effective diagnostic models. He holds advanced qualifications, including MBBS, MD in pathology, international fellowships, and an MBA, alongside auditor role for NABL and NABH. Welcome, Dr. Chirantan.
Thank you, Dr. Manisha. A very kind introduction from you. I'm humbled, truly.
So, Dr. Chirantan, what are the key genetic mutations and molecular alterations commonly found in molecular profiles of non-small cell lung cancer?
Thank you, Dr. Manisha. I think this is a very important topic, not only from a molecular oncology perspective, but from a cancer ecosystem perspective in India today. We are seeing a significant rise in the incidence of non-small cell lung cancers in India, especially amongst non-smokers and amongst women. The trend is going in such a direction that non-small cell lung cancers, primarily adenocarcinoma, may become one of the major cancers or more common cancers in women and in non-smokers. So I think this is a sensitive topic. But besides that red flag of rising incidence, the treatment for this particular cancer has evolved significantly. And we are seeing in current times that non-small cell lung cancer patients, literally it is moving into a chronic disease state. And these patients can be managed and maintained on target therapy and various other kinds of treatments for a very long period of time. So that outcome is coming out of the molecular profiling of lung cancers. So coming to your questions, historically what was happening is that as molecular methods were evolving, we were looking at single genes, again, mainly targeted towards the available treatment option, because there was just one line of treatment, which is a target treatment for lung cancers that was called the EGFR, the epidermal growth factor receptor antibody, or the epidermal growth factor receptor tyrosine kinase inhibitor, TKI, which was the only available drug. But in the last 10 years, we have seen a surge in the availability of target drugs which are very effective. And hence, the profiling of non-small cell lung cancer has rapidly changed from just one gene evaluation to a plethora of gene evaluations. Now, this is increasing, as I said, with our knowledge on in a continual basis. But we are seeing certain genes which are very important to be evaluated for non-small cell lung cancers. As I mentioned, EGFR is one of the primary, but there are genes of targetable interests like ALK, ROS1, MET. Then there are other genes which are responsible for response to immunotherapy, or rather resistance to immunotherapy, like STK11, KEAP1. Then there are certain genes which are rather very ubiquitous in non-small cell lung cancers and may indicate, differential response to first-line therapy like TP53. So there are a plethora of genes. If you were to ask me, maybe there are 10, 12 genes which I mentioned which are of primary significance, but clinical research has shown us now that it's always beneficial to do comprehensive broad spectrum molecular profiling of such patients, because then we not only identify what are the sensitizing mutations against which we have drugs, but also we can find out what are those resistance mutations towards which there is a caution. And I think we will talk about the significance of combination therapies, because when we have resistance mutations, we can circumvent that with combination therapies. So I think that's the profile for lung cancers from a molecular perspective.
Right. So from one gene to multi-gene panels and then targeting the genes, right? So how do you foresee the integration of liquid biopsy techniques with multi-omic data in lung cancer diagnosis and monitoring?
Well, another very important topic, and something which not only specialists in oncology but even patients should know, this technique called liquid biopsy. It has revolutionized in many ways the diagnosis as well as the therapeutic stratification of patients, especially in difficult to biopsy organs like lung. Lung biopsies, as we know, it is an invasive procedure. It either has to be done through an endobronchial endoscopic method, or it has to be done with an expert hand under CT scan or radiology assisted techniques. These are not very simple techniques and have their own risks also associated. Now, having a technology which can basically substitute this, not fully but partially, with a simple blood test can, you can imagine how convenient it is for both the caregiver as well as the patient. So liquid biopsy is that technique where we can isolate the molecular signatures of cancers from blood samples. So all we need to take is a blood sample in a special tube, isolate the plasma, and then extract the tumor DNA from the plasma. And then we can sequence the tumor DNA in pretty much the same way as we do a biopsy, to a relatively higher depth or sensitivity. And then we can find out all those targetable mutations in liquid biopsy. Now, a blanket statement is that liquid biopsy is not a substitute to tissue biopsy till today. We have actually been fortunate to formulate a driving committee or a group of experts in lung cancers within India, and we are coming up shortly with a guideline for liquid biopsy for non-small cell lung cancer. What should every practitioner in this area and every lab which is performing liquid biopsy know about it? It is going to be called as the EIOC consensus guidelines for lung cancers, and it is being led by Dr. Kumar Prabhash of Tata Memorial Hospital, and we have just submitted the final manuscript for publication. So in general, I would say that liquid biopsy can come in the following scenarios. One, when you do not have a tissue biopsy, or a tissue biopsy is not possible to be taken, or the morbidity of the patient is such that a liquid biopsy would be more convenient. Two, when you are expecting a molecular resistance mediated heterogeneity in the tumor, which may be skipped if you take the biopsy from a single location, because needle guided biopsy from a single location will give you the picture of that site of the tumor, but may not be representative in case a tumor is spreading and is growing in many different areas within the lungs or even in other organs like the liver or lymph nodes. So in those instances, when we obtain liquid biopsy, we get rather homogenized tumor DNA material, which we can sequence. So it gives us a broader information about the resistance patterns and the novel heterogeneity developing in the tumor. This is also significant in patients who have progressed on multiple lines of treatment, because obviously, when there is lack of response to a certain line of treatment and the tumor is progressing, we are always concerned of the fact that what are those mechanisms which are leading this tumor to evade the treatment that we are giving. So in those instances also, liquid biopsy literally helps us a lot. In our center, we have published our data of Western India, which we presented at the World Lung Cancer Congress this year. We saw a much higher pickup rate of these resistance mutations when we do liquid biopsy, uh,
Mm,
as compared to the tissue biopsy.
mm,
Of course, uh, a very advantageous method could be if we could club the tissue biopsy and the liquid biopsy, because the sensitivity is addressed by the tissue, whereas you know the differential expressions is addressed by the liquid biopsy. But that may not always be possible based on resource constraints, etc.
mm.
So that is the plethora that liquid biopsy addresses, the plethora of questions that liquid biopsy addresses. Again, we are seeing more and more evolution in the area of liquid biopsy, and I'm certain that in times to come, it is poised to become the first line of diagnostic and theranostic modality for non-small cell lung cancers.
Right. It is definitely complementing the biopsy. That's what I can make out.
Yeah.
Right. And we are awaiting the guidelines.
Mhm.
How can integrating proteomics and genomics with histopathological examination contribute to more personalized therapeutic approach for lung cancer patients?
I think again a very important question. In fact, this is throwing light towards the future. Now, what we have observed is each of these areas addresses specific clinical questions: histopathological diagnosis of the typing of lung cancers into small cell and non-small cell, squamous cell and adenocarcinomas, and the other more complex and rarer subtypes, genomic classification of the lung cancers. We are there, up till this stage. But looking into the future, we also see or try to find modalities of treating those complex cases, as I mentioned, which have shown resistance to any of these available treatment lines, be it chemotherapy, target therapy, or immunotherapy. Now, the question of immunotherapy is also very, very vital for non-small cell lung cancers. In fact, in most guidelines, it is an option even in the first line setting of lung cancer if the immunotherapy markers like PD-L1 are positive. But what happens is that when the patient progresses after all these treatments have been given, that is when we have the confusion, and we are looking for options how to, address or target this tumor. And that is where amalgamation of genomics with transcriptomics and proteomics uh, comes to aid and becomes a very, very strong tool. And that is also a scenario where we can use drugs which are possibly approved in another organ system to help us manage this given tumor. So when we talk of proteomics, it's basically looking at protein expression on the surface of cells. We can do this on the tissue biopsy, and now with modern modalities we can even do this on circulating tumor cells. Now, this technique helps us identify cell surface protein receptors like VEGF, even EGFR, uh, esoteric markers like androgen receptors. There are certain rare lung tumors in non-small cell lung cancer category which can express hormonal receptors and hence may be amenable to anti-hormonal treatment as an additional maintenance.
Mm,
So those, modalities of where we can target these cell surface protein receptors, or even help in prognosticating the cancers, is an area where coupling genomics with proteomics is a very advantageous modality. I'll give you an example. It's very common to find non-small cell lung cancers with EGFR mutations. But the co-occurrence of EGFR with any of these other genes, specifically with TP53, which is one of the most common co-occurring mutations, can give you new light towards how these patients can be successfully treated. Whether you want to stay with a single agent anti-EGFR drug or EGFR TKI, or you want to couple it with a chemotherapy, or now certain new studies have shown that if you can couple the anti-EGFR therapy with VEGF blockers like bevacizumab or Avastin, the success rate is much higher in terms of outcome in cases which have EGFR and TP53 co-mutations. So I think those are the complexities that a multimodal approach or multi-omics is pegged to answer. Again, something which the entire oncology community is very strongly looking at. We are actually anticipating some new platforms or, analysis instruments which can help us do genomics and proteomics parallelly. So, that's going to be so super interesting when the oncology community gets a modality which is like really a one-step test where you can get the genomic data and the proteomic data together and then can compile your report based on that. So interesting times ahead.
Right. Right. So multi-omics, definitely it is going to be there and help us, guide the treatment for lung cancer in a better way.
Right.
So my next question is that how do molecular profiles of lung cancer evolve during treatment, particularly in cases of resistance to targeted therapy and immunotherapy?
Wonderful. Um, Cancers are a compilation of intelligent cells, in their own way, in the sense that first of all they have evaded the normal cellular mechanisms of physiological, well-being, and they have uh, attained that aggressive phase that they can multiply and evade cell death or apoptosis. So they are already genetically evolved, I would say, as compared to the normal cells. And then uh, when we challenge them with treatment, for example, chemotherapy or target therapy, these cells have a tendency to, take that uh, genetic evolution to a next level, that they develop mechanisms that they can evade these treatment options. Now, very commonly seen is non-small cell lung cancers progressing after the first line of chemotherapy or a platinum doublet therapy. Also, very frequently seen is non-small cell lung cancers which had one genetic target or one genetic driver in their baseline evaluation, like an EGFR mutation, for example, an EGFR exon 19 deletion, acquires other genetic mechanisms or alterations which then start driving the tumor. And this again goes back to the point that we discussed about the advantage of liquid biopsy, that it's a modality to pick up all these rare mutations which may be coming up from different clones of the tumor cell population. So the evolution of resistance mutations is very interesting, very important. Few of the very common ones that we see, as I mentioned, TP53 mutations, somatic TP53 mutations in resistant cells. The other very common and very challenging one is KRAS gene mutations, or the Crichton-Rat virus gene, which is posing a totally new challenge now in lung cancers as well as in many other types of cancers like hepatobiliary and colon cancers. KRAS mutations renders these tumor cells not only more aggressive to the growth pattern, but also resistant to multiple lines of treatment, target treatment as well as immunotherapy. So, and then we can subdivide these mutations also into different categories. For example, now research has shown that KRAS G12D mutations are more amenable to immunotherapy as compared to non-G12D mutations. KRAS G12C mutation is one category where newer target drugs have also evolved, like adagrasib and sotorasib, which are now available for that particular mutation. So, mutations are driving us to find more and more target drugs. A difficult area is when PIK3 alterations and CDK pathway mutations develop as resistance mechanisms. But again, We have drugs against PIK3 pathway or mTOR pathway, as well as CDKN2A, CDK4/6 inhibitors, which can act on the cyclin-dependent kinase pathway. So these are, for example, the CDK4/6 inhibitors are were primarily an indication for breast cancers. Now we have found their application even in lung cancers. So this is how we are looking at molecular mechanisms of evolution and then looking at off-label or multi-organ, organ-agnostic application of drugs that we can apply that. And we are seeing responses as well, fantastic responses.
Right. So, with this discussion, we have got to know that molecular profiling is definitely guiding us. And so, my last question to you is that what are the challenges and opportunities in integrating molecular profiling data with clinical decision making in lung cancer, and how can we address it and make the treatment better for lung cancer patients?
I think you have kept the cream for the last. So this is a very important question from from a policy making perspective, I would say. So the challenge is that of resources, of financial assistance. Um, Patients still have to pay for most of these molecular genetic tests out of pocket. In a resource constrained country, I would say still in the tier 2, tier 3 cities and from villages, patients find it difficult to afford for these broad spectrum genomic tests, given that they can cost from anywhere ahead of 50,000 rupees to even a lakh rupees. Smaller genetic profiles of 10, 12 genes are much cheaper. They're also oftentimes funded by the pharmaceutical companies who may provide the drug as a reflex to these genetic tests. So I would say the primary question that we face, at least in the clinical practice, is that of the affordability to avail these genomic and multiomics tests. The other, I think, is also a knowledge gap, because the genetic science has evolved at such a pace that there are knowledge gaps at multiple levels. I would say, at our center, like in Mumbai, we find the oncologists are very pro to molecular knowledge and incorporating it into their practice, but that may not be the case across the spectrum in the country. In the laboratory where the primary workup of the patients is done, oftentimes many things are missed at that stage also because of a lack of knowledge availability. And so the first one was financial issues or challenges. The second is an educational or a knowledge-based challenge. And the third is an application challenge, because I think there are lot many labs and service providers which have come up in the recent years, which are providing these molecular genomic techniques, and which is very good. But I think still there is requirement to harmonize all these various different laboratory techniques, laboratory tests, and to really make it a one platform with the clinical need. So I think if we can create bridges between the financial support system, the knowledge support system, and the service providing or the infrastructure support system, then we have a broad platform, a stable platform on which we can grow this, building of support for non-small cell lung cancers. Again, a growing issue in the country. So
yes, definitely. And I also believe that advances in understanding the genetic mutations and molecular alterations for the lung cancer has revolutionized the way we diagnose, the way we treat, and we can integrate targeted therapies based on these genomic profiles and make the treatment individualized, personalized for every patient. Thank you, Dr. Chirantan, for joining us on this crucial topic.